Well, welcome. Thank you for joining us this morning. Today, we're going to talk about when it's not just autism, when your child has a diagnosis or a suspected diagnosis of ADHD, anxiety, or some other diagnosis. And what we're going to do this morning is we're going to just go over a brief introduction, and that includes talking a little bit about autism, and then talk about, in a very brief overview way, some frequently occurring, co-occurring, this should say not occurring diagnoses, co-occurring diagnoses. And we're going to take a deeper dive into the two most prevalent ones, anxiety and ADHD, and look at ways that we can try to discriminate between what's anxiety and ASD, what's ADHD, what's ASD, and how we can, even though we in ABA through insurance-based services can't specifically address anxiety or ADHD, can spend some time on skills that can contribute to dealing with anxiety and ADHD. And then we're going to wrap it up. This is being recorded, FYI, but you will not be identified in any way on the recording. So let's just start out this morning with a brief overview of what are the DSM symptoms of autism. And I'm doing this because one of the things that we have to do when there are co-occurring diagnoses is try to parse out which things are autism, which things are part of that other diagnoses, because it will help us to decide how to approach dealing with whatever we're seeing. So the symptoms of autism, according to the DSM, fall into two categories. Problems with social communication, that includes language delays, difficulties with eye contact, difficulties with reading facial expressions, gestures, and emotions in others. So just that basic problem with not being able to read others, right? It may include atypical vocal characteristics. So it may be that the presentation is monotone or flat, or exaggerated, or using an inappropriate voice. I've worked with kids who engage in a lot of what's called vocal fry, where it's just talking like this, or maybe an accent or something else like that. I've had kids do that as well. Difficulties with perspective taking and understanding relationships fall under the category of social communication problems. So when you cannot read others, one of the things that comes as a result of that is that you may also just have basic difficulty with understanding what they're thinking, what they're feeling, and how what you do might affect them in particular as a separate person from you, because not everybody reacts the same way that you do to something. And so understanding that that's true and what happens in those situations, in social situations, and why that person reacted that way and not the way you expected, because the way that they reacted is not the way you would react, is part of that problem with perspective taking. They may have difficulty just with conversation and social interactions in general. So difficulty with starting conversations, not knowing how to end conversations, difficulty with continuing conversations, or being very perseverative and sticking with a particular conversational topic that they feel very comfortable with. And finally, sometimes folks characterize it as a lack of interest in others. I don't necessarily see that as being sort of a core thing. I think that that comes because of some of these other things. If interacting with other people is very puzzling and difficult for you, then that's something that's going to be of less interest to you than things that are understandable and that you don't have to work as hard at. The second category is repetitive patterns of behavior, which includes restricted interests and resistance to change. And that's where you see preference for particular things, rigid habits, like always eating the same food every day, playing with things in ways that are atypical but are repetitive, having very, very restricted and unusually intense interests with a particular object or a topic, knowing everything there is to know about a thing. And resistance to change, really, preferring those very set patterns of things. Getting upset when you have to take a route home, or if the routine for something changes. Those are the two basic categories that are encompass the basic symptoms of autism from a DSM perspective. Those things present into other things. So when you have difficulties with social communication, or you have resistance to change, you can see behavior problems that arise from that. You may see more frequent tantrums, or alternative ways of trying to communicate, because communication, right? If they have language delays or other kinds of social communication difficulties, these other ways of communicating with you will arise. And those are things that we see that come from these symptoms, according to the DSM, but they're not one of the symptoms, which is why sometimes you see kids that don't have those things, right? Like, not every kid has tantrums, not every kid has self-injurious behavior or whatever. It's because those things aren't necessarily part of the symptomology. They're things that come into play because of the symptomology. All right, so that's the basic nutshell of autism, right? And what are some of the other diagnoses that we might see? So when we talk about co-occurring diagnoses, that is a medical or a psychiatric condition that occurs alongside autism. So something that is occurring at the same time, but is not a part of the autism diagnosis. And interestingly, at least, or not at least, but nearly close to 3/4 of children with autism are diagnosed with something else in addition. So it's a very prevalent thing for there to be more than one diagnosis. The diagnosis can appear anytime during the development, so it doesn't necessarily have to be diagnosed as the same time as autism. And you will often see that the autism is diagnosed first, and then later there's another diagnosis, or vice versa. I've had kids who have a particular other diagnosis, a co-occurring diagnosis, and then later in another pediatrician or PCM or will come along and say, oh, you know what, actually, there's some things here that are consistent with autism, and give them that diagnosis as well. Knowing what those co-occurring diagnoses are and what they look like and what things that they present can help us when we're trying to develop out our treatment for the symptoms and problems that arise because of autism. So it's knowing can affect how autism therapy occurs and how it supports your child. And so it's important to identify and diagnose those conditions and manage them separately, but also know that they're there and how they are affecting your child, so that we can take those things into account when we're developing our therapies. So let's start with just a brief overview, and then we're going to take a deeper dive into anxiety and ADHD. So I'm not going to dwell on these two, but we're just going to overview them at this point. So anxiety is characterized by tension and restlessness and hyperactivity, with worry and fear. Those things for kids with autism tend to manifest themselves as things like asking questions over and over again, having trouble sleeping, potentially engaging in self-injurious behavior, and social anxiety, because if you are having a difficult time interacting with other people, then that becomes an aversive situation. And then you know that you're going into an aversive situation. And so you have some anxiety about that. 40 to 60% of children with autism have a diagnosis of anxiety or qualified to have a diagnosis of anxiety. So that's a pretty high number of kids, right? And so and that's one of the reasons we're going to look at that one a little bit deeper in a few minutes, because it is one that happens frequently, and that presents some symptoms that can look like autism, and also is interwoven with autism in various ways, like I was alluding to a minute ago, having to do with the social anxiety, right? The common therapies for anxiety include cognitive behavior therapy, teaching relaxation techniques, and medication for anxiety, specifically for anxiety. There's a variety of anxiolytics that can be used to treat anxiety. The second most frequently occurring co-occurring diagnosis is ADHD, and that affects anywhere from 30 to 80% of children with ADHD. And I know that's like a wide range, but that's what I'm saying there is that 30 to 80% meet the criteria. They're not always, and that depends on which source you look at, and they're not always diagnosed with the ADHD, but they have symptoms consistent with it. So those symptoms include things such as difficulty with thinking before they act, so impulsiveness, difficulty sitting still, and difficulty focusing. And some of those characteristics, some of those symptoms, they are common to both autism and ADHD. Right? So sometimes it's hard to separate out which is which here, what's going on. Importantly, ADHD creates barriers to learning. So it's because of the difficulty with sitting still, the difficulty with focus and so forth, it can create these barriers that make learning, whether that's in an academic setting or in an ABA therapy setting, more difficult. The common treatments for ADHD include behavioral treatments, which can include things like ABA, although it's not separately, to be treated by ABA, it would have to be separately diagnosed and separately prescribed as a treatment for ADHD. Relaxation techniques, and also for ADHD, I'm sure you know that one of the most popular ones of those things is medication. There's a wide variety of medications for ADHD. We're going to take a deeper dive into ADHD in a few minutes. Depression, which often goes hand in hand with anxiety, can also be common in autistic children, especially among those children who are aware that they're different from others and who experience bullying and who just really recognize that they are struggling to interact with their environment. The symptoms that you might see for depression include a low mood or a cranky mood, poor sleep, which is, again, something that we saw in anxiety, poor appetite, general irritability, loss of motivation, so loss of interest and motivation to engage in all kinds of activities. We find that because depression can often stem from the way the person is interacting with their environment, that autistic people might be more likely to have symptoms of depression if they also have more severe characteristics of autism, if they're older or if they have a higher IQ, so that they've been experiencing difficulties in interacting with their environment for a longer time, have a greater awareness of that, or if their symptoms are more severe. When we're looking at how depression might interact with ABA, one of the key things is that it can increase or it can decrease motivation and can affect reinforcement, or what people enjoy, what they're willing to work for, what will help to support them. And as a result, it's really important for us to know if a child has depression in addition to ADHD, because in ABA, what we're doing is we're trying to give them access to things that they really, really love and enjoy, right, as a reward for doing things. And if they don't have things that they really love and enjoy, if their low motivation is very low to engage in things, that makes our job different, right? We have to work on things differently as opposed to having that same sort of focus on finding and allowing them access to the things that they really enjoy. And it affects how we identify their motivation, what we do to motivate them. And it's important that we are aware of a child if a child has a co-occurring diagnosis of depression. Behavioral treatments for depression include, again, behavioral treatments, which can include cognitive behavior therapy, which was, you may remember, used for anxiety, and other kinds of behavioral treatments, and medication. There is also a wide variety of medications for depression. They are not always indicated for people younger than 21. Actually, some even put that age a little higher because they can have some paradoxical effects. And so if they are in use, it's important to monitor closely how they're reacting to those medications. About 40% of children who have Down syndrome are also autistic. And that doesn't, and I want you to notice I didn't say 40% of autistic children have Down syndrome. It's, in this case, I'm reversing that and saying 40% of children with Down syndrome have autism. And the Down syndrome, unlike some of the other things that we've talked about so far, is a genetic disorder. So most people have 23 pairs of chromosomes. People with Down syndrome, which is also called trisomy 21, have an extra 21st chromosome. And that expresses itself with characteristic facial features, with developmental and intellectual delays, usually poor muscle tone, potential hearing and vision problems, and frequently congenital heart defects. One of the things that Down syndrome is characterized by is that intellectual and developmental delay. And when that's along with autism, it affects the speed of learning, the motivation, and retention. So it's also important for us to be aware of a child's Down syndrome diagnosis. Now, typically, that's not a problem. Most people are aware, and Down syndrome is diagnosed and in infancy. So they're aware that their child with Down syndrome has Down syndrome. They're aware that their child has Down syndrome, right? And so it is typically diagnosed before autism, right? That's usually diagnosed in infancy. Autism may be diagnosed later. But it does affect their speed of learning. It affects their motivation and their retention. So it's important for us to be aware of it as well. The treatments for Down syndrome, and because it's a genetic disorder, is not what you would say is a curable thing, but then are any of these things, right? We provide treatments for them, which can include behavioral treatment, and then there are health problems that are associated with Down syndrome, which can also be treated. Right? But what we're going to do when we have a child with Down syndrome is we're going to approach the learning and how we teach a little bit differently, taking into account, right, the fact that the Down syndrome affects that speed of learning, that it affects the motivation, and that it affects the retention. So, for example, we're going to be going back to skills, already learned skills, frequently to make sure that they are still strong and they can still do those things, and reteaching occasionally whenever we need to. children with autism are frequently diagnosed with gastrointestinal symptoms. And they just generally speaking, autistic children and children with developmental delays appear to have more gastrointestinal symptoms than other children. This has led, of course, to all kinds of theories about why and exactly what the relationship is between the GI system and autism. Then there are some possibilities, for example, altered gut bacteria, increased gut permeability, a longer food transit time that it takes to get things through the gut, and low fiber intake. So it's just generally speaking, the restricted diets that we often see with kids with autism may be things that are producing those GI symptoms, which can include chronic constipation, abdominal pain, diarrhea, fecal incontinence, or being constipated, in reflux, in particular gastrointestinal reflux disease, which is also known as GORD, and bloating. Those many children experience those kinds of symptoms. There is, however, I want to point out, no evidence to support the use of the gluten-free and casein-free diets. So while we know that there's a higher prevalence of GI symptoms in kids with autism, there's no conclusive right now evidence to support the need for those diets. Of course, a child with autism may have gluten intolerance or other food sensitivities, allergies, or intolerances, right? Just because all people can have those things. And it is even possible that they have that at a higher prevalence. But what the specific relationship is between those things, whether one is causal, right? So does having autism cause the GI problems? Does having GI symptoms cause autism, or is it that there's some third factor causing both things? Is unknown at this point. And people are doing research on that all the time. It would be very, very useful for us to know what the actual nature of that relationship is. The kinds of therapies that then are prescribed for GI symptoms, which are done by pediatricians or GI specialists, can include an altered diet, stool softener, laxatives, increased water intake. There are some things that it can interact with from a behavioral perspective. So if a child has difficulty with eliminating and difficulty with their bowel movements, that may produce a situation in which that becomes an aversive event for them. And then they won't even go into the bathroom, for example. And that is something that we can address things like that. That's not about their actual GI problem. That's about how they're reacting to their GI problem, right? That's about how they're reacting to the fact that they've been constipated. And so that's a behavioral problem, not a GI problem. So there are ways in which what we work on in ABA can support some of the things that result from the GI problems, but we are not actually specifically addressing those GI problems ourselves. I talked a few minutes ago about about Down syndrome, and one of the characteristics of that is intellectual disability. But a child does not need to be diagnosed with Down syndrome to be experiencing an intellectual disability. In fact, 20 to 30% of children with autism have an intellectual disability, with another 20 to 25% having a borderline intellectual disability with an IQ that falls somewhere between 71 and 85. Intellectual disabilities are characterized by trouble with verbal skills, talking, listening, and understanding, but more specifically with slower learning of skills. right? So there may be delays in things, but it's generally speaking, it's the speed at which learning occurs that is the real barrier when we start to look at how to address it. I want to point out, however, that autistic children with the intellectual disabilities might have uneven skills. So there may be some things that they're really, really good at. And then there are other things that they find to be really, really hard and have a really hard time learning those things. What we do know is that early intervention and education can support people with intellectual disabilities and can help to remediate some of those disabilities or some of the delays if they're approached appropriately. So behavior therapy that's focused on learning and social skills is an important component of addressing intellectual disabilities in the different ways that they're displayed. And we can, what we do in ABA has to be separated out in terms of, or what we do in ABA related specific to autism, okay? Because ABA can be used in many different ways, including in the school system, where they are specifically addressing academic and delays and intellectual disability. But what we can do are focus on things that provide foundational skills and that work on social skills. Both of those things are important for addressing the delays that occur in intellectual disabilities. Similarly, speech and language delays and disorders are something that can occur, that we in ABA can work on to some extent, because we're working on some of the foundational kinds of learning skills, right? And things that are related to social communication, because that's part of what happens in the speech and language delays. But when there is a speech or language delay, it's important to have that be separately diagnosed and treated through speech therapy as well. Speech therapists have specific training in identifying what deficits there are and knowing about things like what is the best order to teach different kinds of skills related to speech. And also, they are specially trained to deal with the mechanics of speech production. So they are, experts at how our mouths need to move, what muscles need to move, and in which ways, how the tongue needs to move. Those are things we don't know about in ABA. And so when there's a speech production problem, for example, it's really super important to have the speech therapist be addressing those mechanics of speech, right? How does that tongue need to move? How do your lips need to move? How wide is your mouth? What happens with your jaw? All those things that that are involved in speech production. Okay. If there's some behavioral components to that, including having to do with motivation and so forth, then we're the people to step in there, right? But the best possible scenario is that your speech therapist and your ABA therapist are communicating with each other so that each can be addressing the things that they specialize in and can be talking back and forth and being collaborative about that. Okay, so if there is a speech or a language delay or disorder diagnosis, it's important for us to know that in ABA so that we can get in touch with your speech therapist, so we can talk with them about the best ways that each of us can bring our skills to the table to support your child. Similarly, when there are motor difficulties, which 80% of children with autism have some form of, which can include fine and gross motor skills, including those motor skills of the mouth. It's important that that be also diagnosed and addressed separately from the autism, and be treated with the right kinds of therapies, which can include occupational and physical therapy. So just like with the speech situation, knowing that that's a separate issue, having that addressed by those experts, and that we know that it's being addressed by those efforts so that we can be in touch with them, we can coordinate with them, and we can work together with them. About 20 to 30% of children with autism have epilepsy. And for those who have seizure disorders, including epilepsy, it's most common in children under 5 or then when they hit their teenage years. The seizures can be temporary, so they can be a temporary period of unconsciousness. They can be unusual movements or staring. That's some absence seizures can involve just sort of staring off into space. Or they can be the more classically identified seizures, so they can include, convulsions. I think it's important to know that not all seizures are convulsions, however, right? Just kind of like spacing out or seemingly being unconscious can be a symptom of epilepsy or a seizure, or can be associated with a seizure. That can be really hard to notice as a separate thing, right? Because a lot of times our kids with autism will just, they'll fail to respond. They won't respond to their name. They'll do repetitive things. And some of those things look like, from on the surface, also look like what a seizure might look like. And so it's hard to often identify those non-convulsive seizures in kids with autism, and a neuropsychologist or a neurologist can help with that identification if you have any suspicions that that there might be convulsions and seizures going on, or they're not convulsions but seizures. Treatment for epilepsy can include anti-epileptic medicine, but also some behavioral things like getting enough sleep and avoiding stressful situations. And it's important for us in ABA to be aware that there's a co-occurring seizure disorder, because one of the other things that you often find is the amnestic effect. So after a seizure, things that you learned immediately prior to that, you don't remember them. And so that can affect how we are delivering our therapy and making sure that we're going back and reteaching skills or checking in on skills to make sure that they're still strong and fresh. Besides just being aware that, knowing about it so that we can look out for it and know what to do when it happens. But it doesn't mean that we might have to go back and teach some skills. And we can teach things like how to deal with stressful situations. So how to engage in emotional regulation skills that can then help to lower the probability of seizures occurring. Many children with autism also, about 2/3 of them, in fact, have sleep problems. And I wouldn't be surprised if your child is one of them, because there's a lot of them. Those symptoms can include trouble falling asleep, trouble staying asleep, night terrors, and sleepwalking. So we often find kids who they won't go to bed at night, or they're getting up early, or they're getting up in the middle of the night. Excuse me. And they're just not sleeping well. And when you're not sleeping well, that creates all kinds of things, right? If you're tired all the time because of your sleep problems, then you react to things differently. And we see that very often in kids with autism. And it creates problems for them academically, because they get to school and they're not able to be attentive. It creates problems at home because if you don't sleep well, you may just generally be cranky and irritable, or you may find yourself sleeping in the middle of the day, which affects school routines and home routines and things like that. So often you'll find that the treatment that's prescribed, quote unquote, for that includes changes in routine, eliminating caffeine intake, increasing exercise can often help, limiting access to screens before bedtime, having bed routines. But those things are not always all that need to be done. And there are a variety of ways through behavioral treatment that can be addressed. Things that involve, I've done things like give kids a bedtime pass. You can get out of bed once because and come and give it to me, and then we'll do whatever. But then the next time you have to go back to bed because you know what else? Sometimes sleep problems are linked back to those anxiety problems that we talked about way in the beginning, right? You're anxious, wake up, you're anxious, and you got to have some way to respond to that anxiety, right? So the sleep problems do not only interact with autism, but with some of these other problems that we talked about earlier. The treatments for sleep problems generally involve behavioral treatments. So things that are either psychiatric or through ABA or medication. But that's usually only recommended, particularly with younger kids, if behavior therapy is not effective. We need to be aware of sleep problems, and people generally are very good at keeping us informed of things about their child's sleep patterns, like they didn't sleep well till last night. But also if there is a overall sleep pattern problem, whether that's falling asleep or staying asleep, we can generally provide some behavioral strategies that you can use to address when those things happen. Right. About 5% of children with autism have a tic disorder, or have Tourette syndrome in particular, or 9 to 12% have some kind of tic disorder. And tics are sudden, repetitive, and uncontrollable movements and sounds. And it's diagnosed when that has been true for at least a year. So small periods of tics generally don't result in a diagnosis of a tic disorder. Those disorders, Tourette's and tic disorders in general, can be managed through behavioral treatments and through, again, like with sleep, medication, only if the behavior therapy hasn't been effective. It's important for us to know that there's a separate diagnosis, however, because those things tend to look a lot like some of the repetitive movements that we see that have a different kind of function, right? Those self-stimulatory functions, those repetitive movements that we see in kids with autism are happening for reasons, generally speaking, other than what's causing tics, right? So it's important to be able to separate those two things out and know that this is a tic and not an autistic-based self-stimulatory behavior. I'm actually quite against providing treatment for self-stimulatory repetitive behaviors. I think they're occurring for some function for the child. They provide them with something, whether it's some soothing effect or some input, sensory input or something like that. And we need to be able to find a way to help them get that same sort of effect, right? And that can involve just letting them engage in those self-stimulatory behaviors. Tic disorders, though, tics, right, are not, generally speaking, for those same functions. They're not self-soothing things, for example, or just stimulatory. And so there are ways that we can help to control and manage tics. And so it's important to be able to separate those two things out. All right, that's the brief overview, and actually it turned out to not be quite so brief, or brief for each one, let's put it that way, of different co-occurring symptoms. I want to spend, or co-occurring diagnoses. I want to take a little bit of a deeper dive into the two most prevalent ones, anxiety and ADHD. So let's first talk about anxiety. Autism and anxiety can have similar symptoms, such as difficulties in social situations and routine changes. So as you are well aware, autism has one of the things that we see often in autism are social problems. So difficulties with social interactions, difficulty with understanding relationships. Anxiety can have similar kinds of symptomology. However, autism is a neurodevelopmental disorder, while anxiety is a mental health condition. And it is true, however, that research indicates that autistic people are more prone to having anxiety than the general population. And why that is unclear, but it may, it's likely to, at least in part, be true because of the difficulties that folks with autism have with interacting with successfully with their environment and with interacting with other people. If there's any sort of suspicion that there's an anxiety problem, that should the child or adult should receive a formal evaluation by mental health professionals who can can parse that out and see whether we're talking about anxiety or if it is only related to the autism. There are coping mechanisms that are available and services. Behavioral therapies like CBT, engaging in mindfulness, ABA can work on it, but I want to be sure to say each time here that ABA that's prescribed for autism can't work on anxiety, but ABA can be successful for working on anxiety. Social skills training and other things like that can help make anxiety more manageable. And we're going to look at that in a little bit more detail about how that works in a sec. Unfortunately, it can be really difficult to recognize anxiety in children who have autism. There is overlapping symptomology. And so it can be really hard to know whether this is something that is separate from and needs separate treatment from just the autism diagnosis itself. It may also be difficult to recognize it because the child may have difficulty with reporting their internal states, right? If they are minimally verbal, then it's difficult for a child to say, I'm worried or I am anxious. And instead, the child may demonstrate anxiety through some kinds of disruptive behaviors and problem behaviors. And when that's true, right, then it's hard to separate that out from what we see in autism. Other children may be verbally fluent, okay, but they have difficulty understanding their emotions or others' emotions and expressing those emotions. So even though they can, engage in a conversation with you, they don't necessarily have a good understanding of their own emotions, how to describe them and how to react to them. And that's what we call emotional regulation, right? Understanding, being able to identify your emotional state, being able to then react to that emotional state in particular ways in order to regulate it back down to a more even place, right? But they may not have the way to express that to you. or don't have, like, they know they don't feel right, but they just don't know why they don't feel right. And they don't know how to tell you how they're actually feeling. So so then when they go and for, evaluation, it's really hard because they can't express that to the person who's engaging in that evaluation with them. Although it is difficult to recognize, there are behavioral professionals who are specifically trained to do so. So if you suspect that anxiety is present, it does not hurt to have that evaluation done. Um, like it's better to go ahead and let someone tell you, no, it's not anxiety. These things are coming from ASD, right? And then be able to say, okay, well, I'm just going to focus on the ASD. It's better to know that than to have a child who has anxiety that you're just saying, well, it's just about that's just their autism, right? That's just because they're autistic. It's right, that's preventing them from getting the specific kinds of treatments and the specific kinds of adjustments to their other treatments that will best suit them because of the anxiety that's also in place. Some of the symptoms of anxiety that we see both in kids with autism and also those in neurotypically developing populations include a racing heart, muscle tension. When it's very bad, when there's like an anxiety or panic attack, you might see sweating. There's often crying, throwing tantrums and yelling, particularly for those kids who don't have good ways of expressing themselves, but even for ones that do, if that's become sort of the way that they're dealing with things. Stomach aches, repetitive behaviors such as rocking, pacing, and tearing paper can be symptoms of anxiety, which again, I know those are things that can be symptoms of ASD as well. Trouble with concentration and memory, fatigue, avoiding situations such as crossing the street, irritability, muscle tension, already hit that one actually, and reduced amount or quality of sleep. So this, again, can link up with those sleep problems. There are a number of specific ways that it does present. So specific phobias may be one of those ways, which is an intense, irrational fear of something that poses little or no actual danger. That's what a phobia is. And that may arise in the course of autism because of over-responsiveness to sensory sensitivity or sensory stimulations, such as the loud environment. So you may see that come up because your child is specifically sensitive to certain things. They usually involve highly unusual stimuli. So, we've encountered kids who've had phobias to particular advertising jingles, to balloons popping, to vacuum cleaners and toilets flushing, to alarms at school and so forth. But they might also present with other kinds of fears, like fear of the dark, fear of insects, fear of needles. And those are typical both of kids with autism and neurotypically developing kids. But for kids with autism, there are those highly unusual ones are more common. So, the loud noises, toilets, hand dryers in bathrooms, other things that make particular kinds of sounds in particular, or are surprising, things that are not predictable, can then develop into phobias. Obsessive compulsive disorder is a category of anxiety. It's characterized by unwanted and intrusive thoughts and consequent compulsive behaviors. So you have this compulsion, so to speak, to engage in certain things in certain ways. It's important to identify it because while engagement in repetitive behaviors is typical of ASD, right? In OCD, it's more related to distress. And as a result, these compulsions are performed as a coping anxiety, coping mechanism to relieve the anxiety, right? Which is different, likely, than what is causing the similar kinds of behaviors in ASD. Social anxiety is another one of the ways that anxiety presents, and it's an intense anxiety or fear of being negatively evaluated in social or performance situations, and what ends up happening is that you avoid engaging in social interactions and social situations. And it is likely, at least in part, due to social communication impairment, which we know, right, is one of the things that characterizes autism. So it's important for us to be able to address those social problems, those social skills problems, and because if that doesn't happen, it can lead to negative reactions from peers, bullying, or just not being successful in social situations. Separation anxiety is also one of the ways that anxiety presents itself. It arises when the child has to separate from attachment figures. And it's not limited to young children, by the way. For example, it may be experienced when the child is leaving for college. We tend to think about it as being, the kid who is grabbing onto their adult's leg and won't let go when they try to drop them off at school, but it can be also be experienced by older people, and is probably related to social impairment that evokes reactions that in turn strengthen avoidance in the child. So separation anxiety is likely also to be a part of that social anxiety kind of scenario where because there are difficulties with social interaction, right, you avoid going into those situations. Those situations are also new and unpredictable and out of routine. So we know that those are also things that individuals with autism don't particularly enjoy, right? So separation anxiety is likely related to all those things. Now, we do see separation anxiety in all kinds of populations, including neurotypically developing kids. So it is not something that is only happening for our kids with autism, but in their case, it may be exacerbated by those social impairments and by that need for routine and predictability. There are common triggers that you see for anxiety, particularly for those with autism. So separation, transitioning to new environments, meeting new people, right, going into new social situations, changes in routine, social situations in general, and overwhelming environments, which can can also be a trigger. So if those things are true, what can we in ABA do? Well, we can't specifically treat anxiety when the ABA treatment has been prescribed for autism. Right? When ABA is prescribed for autism, we have to focus on the things that are part of the symptomology of autism. Okay. But there are ways that we can help. So we can work on skills related to flexibility. So skills related to dealing with changes in routine, dealing with changes in patterns, dealing with unpredictable things that happen in the environment. Those are things that are related to the autism diagnosis that also contribute to anxiety. Right? Same with social skills. By working on social skills, we are specifically addressing things related to autism, but those things are then also playing into what's causing the anxiety. We can also work on things from the other side in terms of emotional regulation. So problems with identifying your own emotions, problems with identifying the ways to react to those emotions are things that are characterized by autism. However, they are also things that are making your reactions, or the child's reactions to the anxiety-provoking situation worse, right? So by addressing those emotional regulation deficits, we are also then contributing to how the anxiety is being managed. But I want to be clear that we cannot specifically provide treatment like for what makes you anxious or what makes them anxious, but we can, right? From an anxiety perspective, right? We're not treating their anxiety. What we are treating are things related to autism that are contributing to their development and maintenance of their anxiety. Hope that makes sense. Some things that you can do at home, if your child is anxious, they can teach them how to ask for a break from situations. Teach them and support them in breathing, taking deep breaths, taking 5 deep breaths, for example, giving them the opportunities to be active and go for a walk when there is a potential trigger, or just getting a drink of water, something that breaks that anxious response, helping them to get enough sleep, which ties back to those sleep problems from earlier, and eating well, which is also, I recognize, a challenge for many of our children who have very restricted diets. So not all of these are going to be useful for you and your family, but we can also in ABA help to support some of these other things. Like asking for a break, we can help teach the child to ask for a break in situations. All right, let's finish out with a deeper dive into ADHD. So both of these are neurodevelopmental conditions. ADHD is a neurodevelopmental condition that makes it hard for kids to concentrate, to pay attention, sit still, and to curb their impulsivity. Whereas by now, we should all know that autism is a neurodevelopmental condition that causes challenges with social skills, communication, and thinking. And repetitive behaviors are also a part of that, part of the challenges that we experience in autism. ADHD symptoms, which you will see as we run through them here, do tend to often overlap with things that we see in autism. So they are forgetful, easily distracted, or daydreamy. They appear to not listen and have trouble following directions. Does that sound familiar? They're prone to tantrums and meltdowns due to frustration and the lack of impulse control. They might struggle with organization and with completing tasks. My son had problems with ADHD, and he would complete his homework and then not turn it in, for example. They may have trouble staying on task unless an activity is very enjoyable. Or alternatively, they might be hyper-focused on an activity. They can struggle with social skills, and some of that is related to that impulsivity and things like that. They struggle to sit still during quiet activities, such as at meal times or independent work at school. They may need to walk around while they're eating. They have trouble waiting their turn and being patient, and they seem to be constantly on the go or moving, fidgeting and fiddling with things. Now, not every child with ADHD displays those hyperactivity components, right? For some of them, it is really attentional focused, but that you may see kids who are, constantly on the go, or they're interrupting people, they're blurting things out inappropriately. They just are, like impulsive, right? They act without thinking. And they may overreact to sensory inputs, like sound, smells, taste, things like that, and play roughly and take physical risks. Is also one of the things that happens that we see with kids with ADHD. Now, ADHD, kids with ADHD have trouble following social rules, and that makes it hard to make and keep friends, right? So there's frequent negative feedback for acting out and not paying attention, and that can impact their self-esteem and motivation and make that child feel like they're bad or no good, right? But they're getting constant kind of, because they're having a problem with following social rules because of their impulsivities. They're finding those social situations to be very difficult, and they get a lot of negative feedback. They get a lot of negative feedback that they should be able to, like, why can't you just sit still? Why can't you finish that? Why can't you get that right? I know you're a smart kid. Why aren't you getting that right? Right? And that makes them, that really does impact their motivation. For autism, however, the main struggles involve social understanding and communication and repetitive routines and behaviors. Right? So they do have trouble making friends and understanding how to relate to other people and making sense of social cues. But those things may or may not be related to that just general impulse control kinds of thing that's happening for those kids with ADHD. Okay, what can you do for your child with ADHD if your child has ADHD? Well, you can set clear rules and expectations. That's helpful. They know what rules to follow. Now remember that they may have trouble following rules because of their impulsivity, but they know what the expectations are. And so you can help to guide them towards those expectations. Create daily routines to provide structure. Break tasks or break directions and tasks into small chunks so that you're not asking them to do so many things. And we do that with our children with autism as well, right? Ask them to do smaller chunks of things instead of one big long thing so that they're more likely to be successful at it. Use visual prompts like checklists, picture schedules, and sticky notes, like leaving notes on things so they remember to do things. Allow flexibility during homework time for brain and movement breaks. So taking breaks from things. If you know it's going to be a challenge to stay focused, you know that, why not plan for that instead of being frustrated by it when it inevitably happens? Create an organized homework and study area for the child so that there's not a lot of clutter, which can be distracting. And, everybody, when things are distracting, it's either you're spending a lot of time looking at all that other stuff, or you have to clean it up, or a variety of other things. And give warnings about changes in the schedule and explain what to expect in new situations, so that there's some predictability added into their environment. During ABA treatment for autism, we cannot treat ADHD or autism treatment. During ABA autism treatment, let me make sure that I say this correctly, we can't specifically teach ADHD, but there are some areas that we can work on that can help, areas that have to do specifically with the autism diagnosis. Following directions, for example, we can specifically work on direction following, including, with multiple steps, with movement, like, so I need you to go to other rooms and things like that. As was true with anxiety, working on social skills can be super important. And we can help with working on teaching specific social skills, with teaching rule following within those social skills and so forth. And again, emotional regulation. So teaching a child how to, not as much with identifying their emotions when we're talking about ADHD, but in specifically regulating them. So when they are occurring, how do you react in those situations? It is not possible for us to work specifically on things that are ADHD related when there is an ADHD diagnosis. And it is also, I want to point out, really important for us to know if there is a co-occurring ADHD diagnosis, because knowing that there's going to be difficulty with attending to things, knowing that there's going to be difficulty staying on task with things, knowing that there's going to be a difficulty with impulsivity will 100% change how we develop our treatment for the autism. Right? If we are not aware, or if we're just kind of sort of suspecting that this child is having some problems with focus or whatever, it makes it difficult for us to develop our treatments in the most effective possible way. So if your child is diagnosed with autism or with ADHD, or you suspect that they might be diagnosed with ADHD, it's really important for you to communicate that to us, and to because that allows us to develop our treatments in appropriate ways. So if you suspect that your child has any kind of co-occurring condition, it's important to speak with your developmental pediatrician, because knowing about that other diagnosis helps us to make adjustments to how we work, to take the challenges of that condition into account, and to make sure that we are working on things related to autism, and to make sure that we are working on things that can be, that will help to address not just those things from autism that are related not just to the autism, but are also affecting those other diagnoses. And so please let your clinicians know about any co-occurring treatments or any co-occurring diagnoses, so that things can be designed to best benefit your child. Thank you so much for being here this morning, today. And if you have any questions, feel free to reach out to your clinician, or if you are a Greenbox client, directly to me. Thank you.